Good morning, everyone. Thank you for taking time out for this presentation this morning. SARS-CoV-2, the virus that causes COVID-19, was identified through a surveillance system in China established following the 2002 SARS outbreak to detect emerging respiratory diseases. A patient's specimens tested positive for pan-beta coronavirus using a PCR test, but was negative for known human beta coronaviruses. Whole genome sequences of the virus were acquired. Bioinformatic analyses showed a 96% match with a bat SARS-like coronavirus strain. Based on this analysis, bats appeared to be the reservoir of SARS-CoV-2, but the intermediate host animal has not yet been identified. Subsequent studies indicate the virus emerged sometime in November or December. Last Friday, the World Health Organization released a report about the COVID-19 epidemic based on a joint mission to Wuhan, China, by 25 experts from WHO, China, Germany, Japan, Korea, Nigeria, Russia, Singapore, and the United States. On December 29th, Chinese public health authorities declared a cluster of pneumonia cases in Wuhan, a city of 11 million in the Hubei province. Using the pneumonia of unknown etiology surveillance system to backtrack, the first case of the outbreak occurred on December 8th. Early cases are believed to have acquired infection from a zoonotic source, as many reported visiting or working in the Huanan wholesale seafood market. At some point early in the outbreak, some cases generated human-to-human transmission chains that seeded the subsequent community outbreak. A week after detecting the first cluster, scientists in China had isolated the novel virus. China shared the genome with public health authorities globally. You can see from this epidemic curve, which shows the number of people who developed the illness each day and were reported to Chinese public health authorities, that the epidemic rapidly grew from January 10th through the 24th. On January 23rd, China banned travel in and out of Wuhan and the neighboring municipalities. This was primarily the Hubei province, which has a population of 58 million. The number of new cases plateaued between January 23rd and 27th and has been steadily declining since that time. Among 55,924 confirmed cases, most had fever and dry cough. 77% of cases were from Hubei. Median age was 51, with a range from 2 days to 100 years old. Less than 3% of cases were under 19 years of age. Most people had mild illness, but 20% had severe or critical disease. Asymptomatic disease was reported, but appears to have been relatively rare. The World Health Organization stated that it did not seem to be a major driver of transmission in China. Before interventions were introduced, it's estimated that each infected person spread the virus to 2 to 3 other people. The median time from onset to clinical recovery for mild illness was approximately 2 weeks. Preliminary data show that the time from onset to the development of severe disease, including hypoxia, is 1 week. Severe disease or death was associated with age over 60 years old and or having comorbidities. Mortality increased with age and was highest among people over 80. The case fatality ratio among people without comorbid conditions was 1.4%. Mortality was higher among males than females, and a very small proportion of children developed severe or critical disease. The overall case fatality ratio varied by location and intensity of transmission. It was higher in Wuhan than other areas in China and was higher in the early stages of the outbreak. You can see that it dramatically increased as the interventions were addressed and the outbreak continued. In an investigation of 147 pregnant women, 8% had severe disease and 1% were critical. There were instances of transmission within healthcare settings, prisons, and other closed settings, Just over 2,000 lab-confirmed cases were among healthcare workers. In China, the virus was mainly spread by droplets and fomites during close, unprotected contact. Airborne spread was not reported, but the World Health Organization stated that aerosol-generating procedures were not ruled out as a source of spread or could not be ruled out. Fecal shedding occurred among some patients. However, the World Health Organization stated that the fecal-oral route did not appear to be a driver of transmission in China. To be known about airborne fecal-oral routes of transmission. In a setting of extreme social distancing, transmission in China largely occurred in families. There were instances of transmission within healthcare settings, prisons, and other closed settings. The Joint Commission learned that among healthcare worker infections, most were identified early in the outbreak in Wuhan when supplies and experience with the new disease were lower. Investigations among healthcare workers suggest that many may have been infected within the household rather than the healthcare setting. This is a novel virus, making it a very dynamic situation. So we're going to now, the information from China is very informative. We're going to switch now to look at the outbreak outside of China. As of March 2nd, nearly 90,000 cases have been reported globally. 90% have occurred in China, with the remainder spread over 64 countries. The number of cases outside of China has been sharply increasing since mid-February. More new cases per day are now occurring outside of China than within China. Initially, most were in the Western Pacific. Over the past couple of days, that has shifted to the Eastern Mediterranean and European regions. There are hot spots in South Korea, Italy, and Iran. Based on the size, geographic distribution, and epidemiology of the outbreak, CDC is determining risk and issuing travel health notices. Yesterday, CDC reported 60 total cases from 12 states. 22 are travel-related, 11 are believed to be spread person to person, and the remaining 27 are still under investigation. Washington State announced more cases of COVID-19 associated with an outbreak in a long-term care facility. There are now 14 cases of COVID-19 in Washington State, including 6 deaths. VDH has been monitoring this outbreak closely since mid-January and set up an incident command system. Our command staff and our sections meet daily. Many of our communicable disease epidemiologists, all of our emergency preparedness staff, and many others are spending the majority, if not all of their time on this response. We share situation reports Monday, Wednesday, and Friday with a broad audience. We are in constant communication with our local health districts, other states, CDC, and other HHS agencies, VHHA, and many other partners across the state. We are building on lessons learned across the public health system, responding to past emerging diseases, including SARS, H1N1, Ebola, and Zika. We have launched a comprehensive public information campaign. We stood up a COVID-19 webpage early in the response. We continually update the site with the latest information, data, fact sheets, FAQs, and other information. We are actively addressing misinformation and rumor control. We are using social media to convey key messaging. We've had several documents translated into simplified Chinese and other language. We have also stood up a call center, 877-ASK-VDH3. We have also focused on providing specific guidance to targeted groups. CDC has developed excellent information, so we primarily use their information. When there are gaps, we develop guidance for Virginia. This information is also on our website. This slide provides hyperlinks for you to new and updated CDC guidance and information. Of note, this includes strategies for long-term care facilities and a revised patient under investigation for testing definition. CDC posts new or revised information almost daily. I encourage you to check their website frequently. Detecting cases early is a key strategy to preventing spread of COVID-19 in Virginia. CDC has expanded the PUI definition. Patients should be tested if they have fever or signs and symptoms of lower respiratory disease and had contact to a person who had a laboratory-confirmed case within the past 14 days. Also, if they have fever and signs and symptoms of lower respiratory illness and had a history of travel from an affected geographic area within the past 14 days. This information is updated on the CDC website. There's also testing available for patients who have fever with severe acute lower respiratory illness requiring hospitalization without alternative explanatory diagnosis. For any patient who meets the PUI definition, please contact your local health department and infection control staff at your facility immediately. Local health department staff will assist you in getting the specimens tested. The state lab, DCLS, initiated COVID-19 testing on February 29th. They updated their testing guidance, and these should be posted on their website today. The following specimens are required for testing: 1 NP swab in viral transport medium for COVID-19, flu, and RVP testing, 1 OP swab in viral transport medium for COVID-1 testing, and if available, 1 lower respiratory specimen for COVID-19 testing. The estimated turnaround time for COVID-19 test results is 3 to 5 hours once the specimen is received in the lab. The assay has greater than 95% sensitivity and specificity for COVID-19. Currently, positive COVID-19 results from DCLS require confirmation at CDC. As of this morning, 17 Virginians have been tested, 14 tested negative, and results are pending on 3 tests. There is currently no specific antiviral treatment for COVID-19. Prompt infection prevention and control and supportive management of complications is recommended. Patients with mild illness might not initially require hospitalization. Signs and symptoms might worsen in the second week of illness, according to the findings from China. The decision to monitor a patient in an inpatient or outpatient setting is made on a case-by-case basis. CDC recommends that corticosteroids be avoided unless indicated for other reasons because of potential for prolonging viral replication as observed in MERS-CoV patients. Infection control reminders include minimizing the chance for exposures, adherence to recommended PPE, managing visitor access and movement, implementing engineering controls, monitoring and managing ill and exposed healthcare personnel, training and education, and implementing appropriate infection control. Please review the CDC infection control guidance recommendations available through the link on this slide. A list of products with EPA-approved emerging viral pathogens claims maintained by the American Chemistry Council Center of Biocide Chemistry is available at this website on the slide. Products with EPA-approved emerging viral pathogens claims are expected to be effective against COVID-19 based on data for harder-to-kill viruses. Remember to follow the manufacturer's instructions for all cleaning and disinfection products. Specifically for outpatient settings, ensure signs and respiratory etiquette stations are in place and easily visible at entrance points. Promptly identify patients with possible COVID-19 and isolate them from others. Ensure triage personnel are trained to screen patients for travel and respiratory symptoms. If the facility is unable to provide care in a private room and or staff without recommended PPE, arrange for a patient to be seen in a nearby ED. Place a face mask on the patient and have the patient transported by a private car or EMS if they are unstable. Immediately communicate with a receiving ED for transfer of information. Communicate with the local health department if you have a suspect PUI. If COVID-19 is not suspected, please provide care per usual practice routine. Several strategies are in place now for reducing the risk of travelers returning from countries with widespread transmission. Exit and entry screening is being performed at airport on travelers arriving to the U.S. from China and Iran. Exit screening is being performed at the airport on travelers leaving Italy and Korea and returning to the U.S. Contact information for travelers from China and Iran is provided to state health departments, and we are providing public health monitoring. Travelers from countries with a level 3 alert are instructed at the airport to stay home and monitor themselves for 14 days. Travelers from countries with a level 2 alert are instructed at the airport to monitor their health and limit interactions with others for 14 days. If cases are identified, public health will conduct contact tracing. Extending these interventions to other travelers in other countries is underway now. As the global situation continues to rapidly evolve, please refer to the CDC Travel Advisory's website. The link is provided in this slide. They will have the most up-to-date advice. They will be including information on the need to either stay at home or monitor for symptoms on these travel advisories. As of March 3rd, China, South Korea, Iran, and Italy are at level 3. That's the highest CDC level in which CDC recommends that travelers avoid all non-essential travel. The Virginia Department of Health is keeping information about travelers under public health monitoring on its website. So far, we have provided monitoring for 313 persons in Virginia. We have not identified PUIs from these persons under monitoring. CDC has developed recommendations for assessing and monitoring healthcare personnel potentially exposed in a healthcare setting to patients with confirmed COVID-19. Monitoring and work restrictions depend on the worker's exposure risk classification. For a confirmed case, VDH will coordinate with the facility for assessing and monitoring potentially exposed personnel. VDH will be posting Virginia-specific recommendations on our coronavirus website soon. The World Health Organization closely tracks the spread of the virus and would declare a pandemic if they determine it reaches the potential of widespread transmission globally. The public health response is multi-layered. The U.S. has been implementing public health measures to slow and try to contain transmission of COVID-19. Strategies include worldwide surveillance to monitor the number and location of new cases. Medical providers, the front line of public health, identifying cases early. Investigating cases to understand how the virus is affecting people and how it is spreading. Monitoring people exposed to the virus to reduce the risk of transmission. Keeping people who are infected separated from people who are not infected. Although these measures might not prevent widespread transmission of the virus in the United States, they are slowing its spread. This is allowing us to better prepare in Virginia. It's allowing more time for a vaccine and treatments to be developed. We have not had any cases in Virginia at this time. Research for an antiviral treatment is ongoing. On February 25th, the University of Nebraska announced a randomized controlled clinical trial sponsored by NIH to evaluate the safety and efficacy of remdesivir in hospitalized adult patients diagnosed with COVID-19. While there is not a vaccine, NIH research and development is ongoing. Until a vaccine and treatment are available, non-pharmaceutical interventions would be key to responding to local community spread of the COVID-19 virus if it were to occur here. These community mitigation strategies are actions apart from getting vaccinated and taking medicine that people and communities can take to help slow the spread of the virus. They include personal actions, personal protective measures such as respiratory etiquette, hand washing, and staying home when sick, and community actions increasing social distancing in community settings, and also environmental actions like surface cleaning measures. In preparing for pandemic flu, CDC updated non-pharmaceutical intervention guidelines in 2017. Here are links to that information. COVID-19 seems to be spreading much like the flu. VDH has led robust, comprehensive pandemic flu preparedness efforts since 2004. VDH is actively encouraging partners in all sectors to review their pandemic flu plans and adapt them to this situation. To plan for healthcare surge, educate your staff on COVID-19 and review facility emergency preparedness plans now. Prepare your facility to safely triage and manage patients with respiratory illness, including COVID-19. Explore alternatives to face-to-face triage and visits, such as telehealth options. Plan to optimize your facility's supply of PPE if there are shortages. U.S. healthcare systems are reporting higher than normal use of N95 respirators. CDC is encouraging healthcare systems to implement strategies now to conserve supplies. CDC has provided strategies for optimizing supplies, and they are posted on this slide. VDH does not have PPE available for external entities at this time. Report any healthcare facility supply chain issues to the Regional Healthcare Coalition. Notice on this slide are key CDC resources for healthcare facilities. Please review these guidance documents. There are still things we need to learn about the virus. We still need to understand the source of infection, the pathogenesis, transmission dynamics, the role of aerosol transmission in non-healthcare settings, the role of fecal-oral transmission, viral shedding, risk factors for infection, asymptomatic infection, and seasonality. We need to continue to work across the public health system to share information as this virus continues to spread. So your take-home messages are that there currently are no cases in Virginia. More cases in the United States are expected, though. An effective response in Virginia requires a public health system approach. That's the local health department, healthcare systems, and all of our community partners. Because this is an unknown illness and an evolving situation, there is understandably concern and some anxiety. We in healthcare and public health are all in a position to raise awareness without increasing fear by providing clear, accurate information. Please encourage your patients to stay informed and take everyday steps to stop the spread of respiratory illness. Everyone has a role to play in preparing for COVID-19, and we're all in this together. Thank you for everything you do to protect your patients and your community. We also have a slide on resources and links to the local health department and CDC, and please send any questions to respiratory@vdh.virginia.gov. Thank you.